Welcome everybody. I see we've had a few people joining, so trying not to rush. So welcome to this Campbell webinar on evidence maps. We did have 3 presenters planned. Unfortunately, one of them has had to withdraw because he's not well currently. But I'm sure we're still going to have 2 interesting presentations from Ashrita and Sabina, who are both staff at Campbell South Asia, as Ashrita just said. So Ashrita is director there, and Sabina is one of the evidence synthesis specialists at Campbell South Asia. The AER webinar series, the Campbell webinar series is supported by American Institute of Research, AER, so we're grateful to AER for their support. We have the 2 presentations, so I suggest we do the 2 presentations back to back. But if you want to ask a question, please go ahead and stick a question in the chat box. So at any point you can use the chat and put a question in the chat box, and I'll be keeping an eye on that, and we'll direct questions to the presenters when it gets to the end of the presentations. So Ashrita, over to you, please.
Thank you, Dr. Ovid. I'm just going to share. Yashika, could you please make me the host? I can't share my screen currently.
It's done.
Thank you. Okay, so good evening, everyone. So in this presentation, I'm going to be talking bits about innovations in evidence mapping and some of the current uses of those evidence and gap maps. I'll touch a bit upon automation in evidence mapping that Campbell Evidence and Gap Map have been using, a bit on the equity aspects of it. Like Howard mentioned, we had Monisha who would be presenting about disability evidence and gap map. So I'm going to touch a bit about the key updates that we have done on the disability map and some of the key findings on that as well. So like I mentioned, I'm going to be discussing on what are evidence and gap map, of course, and their uses, use of machine learning in maps and how they're useful. Some of the key innovations in mapping that we have been doing over the years, and how can we introduce equity in evidence and gap maps, and some of the examples from the current evidence and gap maps that we have done. So as you all know already that the language of evidence is now spreading to across all the sectors almost, ranging from international development to health, to education, to social sciences, social welfare, environmental science. The problem that happens with, of course, we're getting more evidence, but it's also going to lead to something called as information overload. So if you look at around 70 million published papers already in the sector of social science and the health out there. So then a question arises, what exactly should we be doing with those evidence and gap map? So obviously the first thing should be synthesizing those evidence so that it is usable. I mean, first of all, it is discoverable, and of course then synthesizing them so that it is usable. So there are 2 approaches to that. The first is evidence and gap map. And of course, the second one is very well-known systematic reviews. Now, this is a snapshot from a paper by Howard White on evidence architecture. What it basically shows you is the top of the evidence pyramid that you see that talks about guidance and guidelines, evidence portals. These are basically the products that inform the decision making without actually looking at the papers from systematic reviews or impact evaluations. But to build that top of the pyramid, what we really require is a strong base of the pyramid that includes systematic reviews, databases, and the impact evaluation studies. The major linking point between the top of the pyramid and the bottom of the pyramid are evidence and gap maps, because evidence and gap maps, they actually help us and they tell us the current state of the evidence base. And unless we build a stronger base, it's not possible for us to actually build the top of the pyramid that is strong enough to be usable for policy decisions and research decisions as well. So what exactly are evidence and gap maps? So typically, I'm sure most of you must have seen by now, evidence and gap map are in the form of matrix of interventions, where intervention forms your rows and your outcomes forms your columns. This is a typical effectiveness kind of map. There are different variants and of evidence and gap map as well, because evidence and gap map, like systematic reviews, can be applied to a range of research questions ranging from process evaluations to country maps. Also, to define an evidence and gap map, they are basically systematic presentation of all the relevant evidence in a particular sector or subsector. But what is important to note here is that typically evidence and gap map are meant to tell how much evidence out there is, and they're not meant to tell what evidence says. And there are exceptions to these gap map, of course. There are some agencies and some organizations, they actually go ahead and they synthesize the evidence as well. There's one example from Campbell review, Campbell evidence and gap maps also, but typically they are meant to say show us how much evidence is out there. So like I mentioned, evidence and gap map, they're typically in the form of matrix of interventions and outcome, where you can see the interventions are forming your rows and your outcomes, they form your column. Apart from this, evidence and gap map, the bubbles that you see, it denotes both the type of the evidence as well as the quality or the confidence rating of that evidence. So the snapshot that you see here is basically from an mega map on child well-being, which included only systematic reviews. So the color coding that you see here, the red denotes a low quality systematic review, whereas yellow denotes a medium quality or the medium confidence systematic reviews, and the green color denotes high confidence systematic reviews. Now, how do we confidence rate these? It basically use a standardized checklist for these. They are available checklist or like show checklist and AmStar rating. This particular rating was done using AmStar 2 checklist. And apart from that, you can also do the navigation of these maps as well. The second snapshot that you see here on the screen is basically from a road safety evidence and gap map that included 96 systematic reviews and 839 impact evaluation. It is again in the form of a matrix of interventions and outcome. Now, how are you going to be navigating these maps? Because these evidence and gap maps, the typical feature is that they're visual and they're also interactive version. So you can actually hover over the bubble and see how many systematic reviews or impact evaluation are there in that intersection of interventions and outcome in that particular cell. You can also click on it and see the number of systematic reviews and evidence and gap map listed out. On the right hand side, you can see basically the information about the study. Typically, these also include the user summaries prepared by the authors, but will also give you the link to the original source of the study. So you can actually click on it and go and read to the original source of the studies, like this. Apart from that, apart from the primary dimensions of the map, which corresponds from the interventions and the outcome categories, typically evidence and gap map also has something called as secondary dimensions. These secondary dimensions can be anything ranging from, are also called filters, and they can be anything ranging from the World Bank region to the countries, to your population categories, or it can also range from funding agencies. And the good thing about, since I mentioned it's an interactive map, you can actually click on your respective choice of the filters, and you can only see the evidence related to that particular filter that you have applied. So let's quickly look at some of the uses of evidence and gap maps. Of course, one of the key uses is it helps guide users to relevant evidence that can help inform the interventions and outcome implementation. Second, importantly, it will help identify existing high quality reviews that can be used for policy decisions, and also can be used to build the top of the evidence pyramid, which I showed you in the form of evidence summaries and used in evidence portals. The third important use of evidence and gap map are they can help and tell the implementing agencies where there are no relevant evidence, or it can also point out the areas of absolute gap where there are no impact evaluations that have been done so far. And fourth, of course, it will help in identifying research gap in the form of impact evaluations and in the form of systematic reviews. Now, like I mentioned, there's already information overload out there, and one of the problems that happens is what to do with them. The second thing that happens is once you start doing evidence and gap map or systematic reviews, there are questions about timeliness. So, for example, you have chosen a topic and you identified number of systematic reviews and impact evaluations to be screened. Now, machine learning can actually help you reduce your time and reduce your load, and of course, reduce the human resources used in the different parts of your systematic review process. A more detail about the machine learning and epi review, you can actually look at a paper by James Thomas, where they clearly mention how machine learning is being used in evidence mapping and epi review. Not just evidence mapping, you can also use this in doing the systematic review steps as well. So one of the key thing we use machine learning and in Campbell maps was assisting in searches. So Epi Reviewer currently contains information related to Microsoft epidemic, which includes about 250 million records, which are quite similar to how Google Scholar works. So Epi Reviewer, they are now linked to Microsoft epidemics, and once it is enabled, you can do three things with it. First is you can perform new searches in the form of Boolean searches to identify studies that are relevant for your research question. Importantly, it can help you in updating your review. So, for example, you have already identified a set of studies in your phase one or in your previous updates. So, you can use this machine learning to actually identify relevant, studies that are there as included in your previous updates. The third thing that it can help you do is keep your map up to date in the form of living systematic reviews and evidence and gap map. Like we have, I mean, there are a lot of places where it has been emphasized that evidence and gap map, they are most useful if they are updated and if they are living. Otherwise, there's no point in doing an evidence and gap map, and we'll see why they're important in my ending slides, and why updating evidence and gap maps are quite important. The second way you can use machine learning and evidence mapping, and we have been using in Campbell evidence and gap map, is screening. So machine learning basically helps increase the efficiency of screening because it will help you identify the most relevant research, and it will show you those most relevant papers at the first stages of your screening. So your entire data extraction time and everything will get reduced in that sense. But currently, you cannot use machine learning. It is not recommended to use machine learning alone. There should be someone who is double screening along with the machine learning because they are still in the testing stages. But otherwise, they do help reduce a lot of your human resource, and it help reduce your timeliness in doing systematic review process or evidence mapping. Now let's look at some of the innovations in mapping and some of the strategic uses of these maps. So I'm going to take you through some of these innovations in mapping in terms of map of maps, mega maps, and how they have been used over the years. So this snapshot that you see here on the screen is basically from a map of maps. Basically, it was funded by CEDL to identify topic areas for new evidence and gap maps in the international development. So this map of maps, it maps all the existing evidence and gap maps in the field of international development, and it helped identify 55 completed and 18 ongoing evidence and gap map. So as a result of this, of course, there were few areas of key gaps that were identified in the form of transport, energy, and economic policy. So how is this being used currently? As a result of this map of maps, there was a follow-up consultation that happened at DFID that led to the development of 3 evidence and gap maps: disability, access to justice, and transport. So out of which disability is already published, and the 2020 update has also undergone. It's not published yet, but we have findings from the 2020 update. The access to justice and transport, they are ongoing. Now, since disability was of particular interest to DFID, that led to DFID commissioning Campbell and ICD to undertake 3 evidence assessment. These were rapid evidence assessment, and they were done on 3 important topics, that is education, livelihood, and social inclusion. This was presented at DFID consultation under the Panda Institute, and this helped identified, and of course, as a result of funding from these institute, we updated the disability map, and there are now 3 full systematic reviews ongoing on education, livelihood, and social inclusion, currently with us as authors. And also, as an update of this, ICD, they also went ahead and commissioned evidence portal, which is called as Disability Evidence Portal. It is currently not fully, completed with all the studies, but they are currently evidence summaries for around few studies that are there in this evidence portal. Let's look at another innovation, mega map. So this is basically map of evidence synthesis studies that only includes evidence and gap maps and systematic reviews on the effectiveness of intervention to improve child well-being. And this includes currently 484 systematic reviews and 25 EGMs. And again, as a result of this, we were able to identify key gaps in the area of child abuse, governance, child rights, trafficking, and equity. So how's this map being used currently? So as a result of follow-up consultation with UNICEF and Ashanti staff, it led to the production of evidence and gap map on violence against children. And this particular map is already published with, that the phase one of it is already published, which is the search that includes in English language. And also their UNICEF research, they have published number of briefs on the main outcome areas, which covers both the mega map and violence against children. Now, these research briefs, they are used within the UNICEF by various staff in terms of prioritizing the areas where we require more impact evaluations or where we require more systematic reviews, and also to make strategic decisions around interventions. The third innovation is basically in the form of effectiveness and process map of using an example of homelessness. So Center for Homelessness Impact, they funded two evidence and gap maps. The one was the effectiveness map for homelessness, and the second was the implementation issues map for homelessness. The effectiveness map, it included around 394 studies, which is obviously organized by interventions and outcome. And implementation maps includes currently 275 studies, where the column headings are not outcomes, but they were barriers and facilitators. And of course, as a result of this map, we were able to identify some of the key gaps in this area. And overall, this map is under research because there were only a handful of systematic reviews that were identified. So how's this map being used currently? So the first of all, this map was used to identify the three priority topic areas for which systematic reviews was commissioned from Queen's University Belfast. And the areas were the discharge, access to health, and accommodation-based approaches. What was important to note here is that there was no additional systematic review search needed for this. The entire studies, they came directly from the homelessness effectiveness map because it was a systematic map that included almost all the literature surrounding the homelessness. Also, Center for Homelessness Impact, since it's a what work center promoting the use of evidence for approaches to improve welfare for those experiencing a risk for homelessness. Evidence portal were central to CHI strategy. So as a result of these, the studies identified in this map, they were used to prepare the content for the first edition of the evidence portal. And currently, of course, the work is going on to complete that evidence portal for homelessness. Also, the map and the reviews produced on the basis of this map are now currently being used by NICE to inform guidance on homelessness as well. And of course, there's a lot of policy decisions going on at the CHI as a result of this map. Another important innovation was map by Imana Institute. So this map basically summarizes the innovations in tools, metrics, and methods that have been created and applied to understand food system and agriculture nutrition linkages in the last 10 years. So in this particular map, the innovation was that the intervention were defined by thematic pathways or domains through which the nutrition is improved, and the columns corresponding to tool metrics or methodological innovations. Interestingly, this particular map included around 600 studies. So in terms of how is this being used currently, so this map is being used to inform the funding for new studies as a information tool funding the new studies. Another innovation is in the form of country maps. I'm giving example of a country map that was done for Uganda. So the scope of this country evaluation map includes all policy domains that affect the welfare of people of the country and include all types of evaluation ranging from your formative evaluation to outcome evaluation and impact evaluation. Interestingly, again, this map identified more than 500 evaluation since 2000 onwards. How is this being used currently? So this map is currently used in planning process by the Office of Prime Minister there, and is again considered the starting point for use of research, and also to identify areas where they have good amount of evaluation to inform policy and program design, and also considered by summarizing those evidence to inform the policy and program designs. Another example, Youth Endowment Fund map. So YF is a what works center with the purpose for preventing violence among children aged 10 to 14 years, and which includes preventative approaches which can be taken at the rate for the children under the age of 10 years. So the CGM was commissioned by YEF to map these interventions. And this is very, very, includes a large number of studies ranging around 2,000 studies, of which 268 are systematic reviews. So how is this being used currently? So on the basis of the systematic reviews that were included in the map, 15 evidence summaries were identified on the topics such as anti-bullying interventions, sports programs, and these summaries are mainly being used to inform YAF commissioning of interventions along with evaluations of those interventions. Also, based on the systematic reviews that are there in the map, 14 technical reports were written, which were used for the basis of for preparing content for the top 2 level of the evidence architecture. And of course, this may also help in identifying new systematic reviews. And of course, there is a plan in place at the YEF for commissioning these reviews. There's also, these were all about the innovations in mapping. I'm going to very quickly take you through how you can get to the equity aspects of evidence mapping. So there are two examples of this where we explicitly included the studies, and we explicitly wanted to highlight the studies related to equity, one of which is the mega map, the snapshot that you see here. And like I mentioned, this particular map included more than 467 systematic reviews. But when we actually looked at how many of these were actually looking directly at the equity aspect of this, only 13 such studies were identified in the mega map. So when we say equity, we mean explicit equity focus in the form that they either address the equity or they focus on disadvantaged populations such as people with disabilities or women belonging to marginalized communities. Another evidence and gap map was disability evidence and gap map. So again, it is one of the key areas of research. And when we first did the update in 2018, when we published this in 2018, there were already very few studies, and most of them had methodological limitations. I'm going to very quickly take you through what were the key changes that happened from 2018 update to 2020 update. So this particular map, it maps the effectiveness of interventions to improve well-being of people with disabilities and LMIC. So it included both systematic reviews and impact evaluations. So 2020 update, it helped identify 108 additional studies in the map. So the map now contains 274 studies. Of these, 110 are reviews and 164 are impact evaluations. Like I mentioned, the findings of this is not yet published because team is currently working on data cleaning and validation checks. So there might be some reduction in the final number. So they might also be increased if you identify new studies in that case. Looking at the change in terms of interventions. So just to give you a brief background, the intervention and outcome framework for the disability map basically belong to the community-based rehabilitation matrix that includes 5 intervention components ranging from health, education, livelihood, social, and empowerment. So if you look at the change between 2018 and 2020 updates, so the highest number of increase has been in the area of health. But however, if you look at the proportional increase, the number of studies in social and empowerment area, the proportional increase is much more as compared to the health. But of course, the absolute numbers remains low for empowerment. You can see that we only have 7 studies currently in the map. If you look at the outcomes, again, the highest number of increase in the area of health. And proportionately, if you look at the increase, they are again in the area of social and empowerment, but the absolute number, they remain quite low for empowerment. If you look at the aggregate map, you can see that the maximum concentration of evidence is in the form of the health quadrant. So you can see that the health intervention, the health outcome, they take up the maximum number. Just highlighting some of the equity gaps. So even with the number of increase over the years from 2018, the number remains low for studies that address the equity focus explicitly, like targeting disadvantaged population, people belonging to ethnic minorities and conflict affected zone. So you can see that the number of studies are extremely low as compared to the other population subgroups. Very quickly, are there areas of high quality reviews in this particular map? Yes, we were able to identify 23 high quality systematic reviews, or should I say high confidence systematic reviews in that matter, 17 of which were in the health sector. Some of they were distributed in social, educational pillars as well. So these high quality systematic reviews, they can be used for some policy implications. Otherwise, there was significant number of reviews which had methodological limitation, particularly in empowerment and livelihood sectors. Again, if you look at the impact evaluation, there were 18 high quality impact evaluation, most of which were there in the health sector. Area of key evident gap that we identified were in the area of empowerment and advocacy interventions. Livelihood intervention was, again, even now scarcely populated. And we can also identify significant evidence and gap map in the empowerment and livelihood outcomes even now. In terms of impairment type, there were limited amount of studies addressing visual and hearing impairment. The maximum amount of studies we identified were addressing the physical impairment and the mental impairment. And like I mentioned, the confidence in study finding was one of the major gaps. We identified only 23 and 18 reviews and impact evaluation that were of high quality. So I'm going to stop there. I think I've gone a little overboard in my time. So thank you so much for listening. I look forward to your questions.
Okay, thank you, Ashrita. We will move pretty quickly on Sabina, but there was one question from Hamid Khan, which I will ask, which was, can you describe the search strategy you use for an evidence gap map?
Okay, so the search strategy is exactly as systematic as you would do in a systematic review. So it should include, all the key databases. In terms of academic database search, it should include all the relevant gray literature databases, including websites of the key funders and website of the key people working in this sector. And search strategy is important because, if you do not draft the search strategy rightly, there are two things that's going to happen. One is, of course, you're going to miss out on a number of, evidence, number of literature. And your implications and finding would be that there are too low a number of studies in a particular sector, which will not be correct. And this has happened previously where in a map which we were doing, and we had to go and update the map again for the searches because we were not able to identify. So the best thing for any evidence and gap map is you need to identify benchmark papers, and then you need to validate your searches whether you're able to identify those important papers as a result of your search. So I would say it is extremely important for you to capture all the studies and you actually saying that all the relevant literature is there in your evidence gap map.
Okay, thank you very much, Ashrita. Okay, now Sabina, over to you. So Sabina, as I mentioned earlier, is a evidence synthesis specialist at Campbell South Asia in Delhi. He's going to be talking about one of the maps she's been working on recently. Sabina.
Thank you, Dr. White.
Are you able to share your screen? Yes.
Yeah.
Okay. Thank you.
Yeah, I'm trying to make it full screen. Yeah. So good morning, good afternoon, and good evening, everyone, depending on your time zones. So today I'll be talking about this evidence and gap map on social and behavioral change communication interventions for strengthening HIV prevention and research among adults and girls and young women in low and middle income countries. So first and foremost, the acknowledgements. So this AGM was possible due to the funding from the USAID and PEPFAR, that is US President's Emergency Plan for AIDS Relief. And we at the Campbell Collaboration and team members from the IAVI Delhi have worked on this evidence and gap map, and we take the responsibility for this map. And the USA, PEPFAR, or the United States government are not in any way responsible for the findings of this particular map. So I must acknowledge the efforts of all our team members from Campbell Collaboration as well as the IVI. So the team members included Ashrita, Saran, Devilina Bose, Anhad Hundal, Saiful Adi, Shweta Singh, Dakshin Alva, Kritik Goyal, Jesse Joseph, and Solomon Salve. And for the searches, our information specialist, John Ayers, helped us in sort of in conducting the searches for this map. And this map was generated using API Reviewer software. And we would be very happy to acknowledge the support of Melissa Bond and Zach Goose, the support team at API Reviewer, for supporting us during this map. So quickly, the structure of this presentation. So I would briefly take you through the research problem or what is the relevance of doing this map. And then I'll talk a bit about the objectives, followed by the approach and methodology or the conceptual framework that we used for this map. Then I will briefly touch upon some of the findings of this map, followed by conclusions and next steps. So first, I would start with why adolescent girls and young women, they represent a disadvantageous group with respect to HIV prevention research. So I must highlight here that we've used UNAIDS definition of adolescent girls and young women, and females in the age group 15 to 24, they were covered as per this definition. So what is important to note here is that gender and age, along with other disparities resulting from the social, economic, and cultural factors, they affect this group of population, adolescent girls and young women, differently. So if we want to see the gender disparities, like the data from the fourth round of National Family Health Survey of India during the 2014-15 suggests that only 1/5 of women, they had comprehensive knowledge about HIV/AIDS when compared to men. Because more men, like 1/3 of them, had more comprehensive knowledge about the HIV/AIDS. So as many as, it's not only about the comprehensive knowledge, but also if we talk about the knowledge about where to get tested, there were gaps across gender, like there were gaps amongst men and women. The next thing is, like, when we see within the age groups in a particular gender, let's say within women, then we see that they're also differentially vulnerable as regards access to preventive methods, such as access to or adoption of family planning methods. So the data also suggests that the adoption of family planning methods was also lower among the adolescent girls than women in the ages of 20 to 24 years. So we see clearly that, the data supports that there are visible gender and age differences within this particular population. And if we talk of the burden of disease, this UNAIDS data support suggests that 6,200 women and adolescent girls between the ages of 15 to 24 were newly infected by HIV every week. And 50 adolescent girls and women, they lost their lives due to treatable diseases like cervical cancer. So coming to the socio-behavioral change communication interventions. So these interventions, they form a central part of the comprehensive HIV prevention, because they not only help in addressing the behavioral or social barriers, but they also they play a very critical role in expanding knowledge of and access to services. They strengthen equity and participation and assist in addressing gender disparities throughout the continuum of care. So they're very crucial. But what SUG suggests is that the health communication component has not been utilized completely. It is underutilized, because usually what happens is that health communication is added as a component and it is not integrated right from the beginning. So we sort of see that, like, gathering from these existing studies, we can say that it is useful to see the role of social behavioral communication change interventions in the HIV prevention spectrum among adolescent girls and young women in low and middle income countries. Coming to the objectives, like, our chief objective was to map the existing evidence on the use of various socio-behavioral change communication intervention strategies targeted at adolescent girls and young women in low middle income countries, so as to identify areas of gap in the existing research area, and which can guide us in designing better strategies and programs for this particular population group in HIV prevention and research. So now I will give you a snapshot of this evidence and gap map. I will try to zoom in a bit, maybe. Mm. So here on the left hand side, these are the intervention strategies, and within that, within each intervention, we have sub intervention categories. And on the top, you see all of these are the various outcome categories for the map, and under these heads, we have all these are sub outcome categories. So here, the bubble is like the size of the bubble actually represents the quantum of evidence in that particular area. So the bigger the bubble, that means more number of studies are there. And we had color coded these all studies to differentiate between impact evaluations and systematic reviews, as they were the two broad categories that we included in this map. So we had and we also assessed the confidence in findings of the systematic reviews. So those in the maroon, like here, you see they represent low confidence systematic reviews. The mustard ones are the medium confidence systematic reviews, and the green ones are the ones which where we could place more confidence, or we say high confidence systematic reviews. So now coming to the conceptual framework. So here at the bottom, you see this is the main or the broad intervention, which is social and behavioral change communication. And at the top is the intended outcome, which is reduced HIV incidence, improved social norms for care and support of adults and girls and young women. So here are the delivery strategies. Like, how would you deliver these interventions? This would be through community mobilization, behavioral change communication, which could be counseling, which could include one-to-one counseling, or it could be group counseling kind of thing, which might be delivered by certain influencers. And this could also be some advocacy efforts. And in addition to that, we have non-communication strategies, including system strengthening. This could include training of the providers and strengthening the structure or the healthcare services to sort of, add to the interventions. So the next up is the target population. So here we see the individuals for our purpose were adults and girls and young women, along with their influencers, which could be their family members, like parents or parent-in-laws, maybe, or partners or peers, and community members and service providers are also the target population for this particular evidence and gap map. And like this is the conceptual framework though, but I'm just talking about that parallelly. So the determinants of behavior change could be from the demand side, or they could also be from the supply side. And together they sort of make an enabling environment. So demand could be generated from the people who are the like target group of interventions. They by sort of enhancing their capabilities, knowledge, and skills, or motivating them sort of so that their attitudes and beliefs change over a period of time. And similarly, the environment can be sort of changed through working on social norms and role models. And similarly, larger changes in the policies could make an enabling environment. And from the supply side, availability of quality services and prevention measures are from the supply side. So what are the categories of behavior change? So these could be at the level of individual, or they could be at the level of structure or institution, so to say. So the improved self-care and self-efficacy is at the level of an individual. The equitable household and relationship dynamics, mostly at the level of household. Then this is at the level of community, reduced stigma, more space for open dialogues, and improved service responsive quality. This is from the supply side. So these are the intended categories of behavior. Coming to the effective HIV prevention and cure. So these like together behavioral, structural, and biological intervention, together all of these would lead to the our intended outcome, which would be reduced HIV incidence, improve social norms for care and support. But what is important to note here is that our main focus was on behavioral interventions. And if they were in combination with structural interventions and some biological interventions, they were also included for this particular map. So now I would take you through like the primary dimensions, which are the interventions and outcome categories for this map. So we had a total of 4 intervention categories for this particular EGM. So these were mass media interventions, which made, of course, the use of mass media like print media or electronic media. We had community-based interventions. The ones that are given under are the subcategories of community-based interventions. We had interpersonal communication. And finally, we had the ICT, that is information communication technology, and digital media-based intervention. So below this are given the subcategories of all these interventions. So due to lack of time, I'm not taking you through all these, but we'll see if we can find time to discuss these later. So coming to the outcome categories, we had in total 7 outcome categories with subcategories of the outcomes. So the two knowledge, attitude, and skills, partner and relationship dynamics, they were at the level of individuals. Household dynamics, they were largely at the level of household. Social and community norms, mostly, as I mentioned in the framework as well, at the level of community, and healthcare services, prevention, and research engagement were 3 other outcome categories rather. So now talking about the population, as I mentioned earlier, that we use the UNAIDS definition, and the age group for our purpose was 15 to 24 aged women or females in low and middle income countries. And we use the World Bank classification to identify these low and middle income countries. That is countries with $12,536 per capita gross national income for a particular year were like countries below that particular income were basically the low and middle income countries. So coming to the subcategories within adults and girls and young women, we tried to see if there were studies that talked of persons living with HIV/AIDS or female sex workers, pregnant women, and new mothers. These were the further subcategories of the population. So the secondary dimensions of this map included the age group, region, country, influencers, study design, study status, year of publication, and funding agency. So of course, given the paucity of time, I won't be able to give the analysis for all the categories, but I'll try to give of as many as possible. So what was the search strategy? So as Ashrita also sort of discussed the importance of search strategy in EGM. So we used a comprehensive search strategy here. We made use of manual databases searches that were suggested by the advisory board, and some of them included Scopus, Popline, and and in addition to that, the grey literature and institutional repositories and websites were also searched. Again, the list of all these things came from our advisory board and IVI team members. And they were mostly, just to mention a few, some of the sites that we searched were International Center for Research on Women. In addition to that, H3C, BCI, these are like the key websites in this particular region, not region, the research area basically. So in addition to that, we conducted hand searches of abstract books on conferences on AIDS basically, and the citations of included studies are also referred to identify the potentially eligible studies. So now coming to the Prisma diagram, we came across 2,120 studies from the main manual database searches. And another 362 studies were identified using website searches, referring to the papers to identify citations and peer literature searches. So in total, we had like 2,121 and 362 studies in total. When duplicates were identified, like they were removed basically. So we were left with about 2,394 studies that were screened at the level of title and abstracts. So about 1,490 studies were excluded at the level of title and abstract screening. So we were left with 904 studies for full text screening. When full text screening was done, we were left with about 475 studies. And during the validation, we found that there were more a number of papers or articles for a particular study. So we linked those records, and at the end, we were left with about 458 studies which were coded and included for analysis. So the analysis that I'm going to present is based on this number, that is 458 studies. Now I'll come to the selected findings. So I won't repeat all that. We just talked of that. So what is important to note here is that if we segregate these studies by the study design, we see that there were 43 systematic reviews and 415 impact evaluations. And out of these 415 impact evaluations, about 32% were the randomized controlled trials. So let's see from where the evidence comes basically, and if there are differences in study design across the different countries. So we find that about 2/3 of all the included studies, closely 70% of all the included studies, they come from the sub-Saharan African region. And the studies from other region were mostly 15, 13, and 11%, as I've mentioned here in the slides. And there were very few studies from Middle East and North Africa. Barely 1% of the studies were from this region. So if we see by the study design, we see that the sub-Saharan African region has the highest number of studies, be it the randomized control trials or even the systematic reviews. And if we see the South Asian region, we see that there were like 62 studies in total, and only 5 of them were randomized control trials, though 16 studies were systematic reviews. And what was interesting to note here is that in the Europe and Central Asia region, like the low and middle income countries from Europe and Central Asia, there were 14 studies, and about 50%, like 6 out of 14, close to 50%, they were the randomized control trial. So we see the disparities in across the regions in like when it comes to randomized control trials. Uh, so these are the heat map of impact evaluations. So again, here we see that the highest number of studies, they are from the sub-Saharan African region, and within that, South Africa has the highest number of studies. So the red, yellow, and green basically denote the low, medium, and high number of studies. But if we see the heat map for systematic reviews, we see the distribution of studies is relatively better than the impact evaluations. So here again, but several countries in sub-Saharan region, they have like fairly good number of studies here. And we see South Asia is relatively better when we compare it to the impact evaluations like in this slide. So you see the slight difference here. So let's see what the evidence suggests if we seed by population subgroups. So the pregnant women and new mothers as a population subgroup had less number of studies or few number of studies. So was the case with persons living with HIV and sex workers. Now, if we see the evidence by intervention, we see that the interpersonal communication as an intervention, as well as the community-based interventions, they had a higher number of studies compared to the rest of the two interventions. But ICT and digital media-based, we had very few studies, like 28 only out of a total of 458 studies. They were ICT and digital media-based interventions. Mass media interventions were a little better, like 70 out of a total of 458 studies. So I'm skipping this slide. So just I've tried to indicate the number of studies across various intervention subcategories. So please note that this red, yellow, and green is not necessarily for the quality of the quality of the studies, but this indicates the number. Like the less number is shown by red, the medium or moderate is shown by yellow, and the higher number is shown by a green. So we see here all the subcategories under the ICT and digital media-based interventions, they are low in number. The ones in green, the peer-to-peer interaction, the counseling one-to-one, and the community dialects, they are like higher in number. And the ones in yellow, they are various subcategories of interventions. They are like fairly not that low or very high, but medium kind of numbers. So if we see the evidence by outcomes again, we see that certain areas are populated more, like they prevention or the knowledge, attitude, and skills, they had more number of studies. Research engagement had the least number of studies. So same was the case with other social and community norms, like 83 studies were there. I'm not showing the percentages, just the numbers. So healthcare services were like 24 studies had healthcare services as an outcome. Household dynamics and partner and relationship dynamics, they were 92 in total. So what is important to note here is that, of course, one study could have multiple outcomes. So of course, the numbers across the whatever slides I've shown you throughout, they will not add up to the 458 because there could be more than one category coded at the same time. So here also we see that by study design, when we see we see pretty much similar trend across impact evaluations and systematic reviews, like more the number of so that shows that a particular there are certain interventions that there have been more studies, both systematic reviews and impact evaluations, but there are certain areas where there are even less number of impact evaluations as well as systematic reviews. Coming to the outcome subcategories, here you see a lot of red compared to the earlier ones. The outcome subcategories. So again, these red, yellow, green denote the number of studies. So we see the participation in biomedical research and research awareness and benefit participation are kind of lowest number. They have the lowest number of studies here. I won't spend much time here as we talk about it in bit detail in one of the slides. So what are the evidence gaps? So we did come across the evidence gaps in terms of interventions, outcomes, and study population. So coming to the intervention, we found that the ICT and digital media interventions with most of their subcategories were least represented. Folk media and capacity strengthening as intervention subcategories within community-based interventions were less in or few in number. Then home visits and gamification and experiential learning as intervention subcategories within interpersonal communication and interventions also had a few number of studies. Coming to the outcomes, there is a lot of areas where we had less number of studies. For example, joint decision making in households. Then I showed you in the previous slides the research engagement subcategories also, prep or biomedical intervention outcomes, then gender norms and expectations, negotiation and life skills, and the quality of care or satisfaction of and healthcare services outcomes. So they were major gap area. Coming to the population, we had pregnant women and new mothers, persons living with HIV, and sex workers as the subgroups which had less number of studies, as I showed you in the earlier slide. So coming to the conclusions, we see that most of the evidence comes from the sub-Saharan Africa region, and there are very few studies from other regions, be it East Asia, Pacific, South Asia, or Middle East and North Africa. And we also noticed that less number of RCTs were conducted in these regions. And we see that there is a serious lack of studies with research engagement outcomes, and other areas that I just mentioned, there were also fewer in numbers of and I just skipped this part earlier. We had assessed the systematic reviews using the AMSTA2 rating scale, and we found that the majority of systematic reviews, they were rated as being low confidence. Only 4 reviews out of 43 were rated as of medium confidence, and only 1 review was assessed of a high confidence. So we see that we don't have many studies, many systematic reviews with high confidence in their findings. So what do we suggest? So we suggest that these, whatever areas that we have highlighted, there might be more research in these areas to fill the gaps. And also we've highlighted a few intervention areas where there may be more research needed, like ICT and digital media-based interventions or folk media and capacity strengthening interventions. So that is all. Thank you. Thank you for your time.
Thank you, Sabina. So we don't have that long left. I do suggest you look at the chat if you've not done so, where there have been a number of questions that come up, to which Ashrita has been giving answers as we go along. So what I would mention is there was a question around stakeholder engagement, I think from Prachi, which Ashrita did answer. Just to emphasize, stakeholder engagement is very important in doing a map. As you've seen, the MAP framework, that's the definition of the intervention categories, the outcomes and the filters, is really very important. And so it's important to have stakeholder engagement in ensuring you use the right framework, either in selecting an existing framework that's already accepted by the community, or if one doesn't exist, in having stakeholder engagement and buying into the framework you develop with a stakeholder consultation process. Even getting the scope and what sort of studies you include and not include, what sort of research questions the evidence addresses is important on having stakeholder engagement. There was another question around machine learning, just describing the process in a bit more detail, which the answer is there, won't repeat it, Ashrita may want to elaborate it, and asking about software you can use for machine learning. So there are several softwares available that do machine learning assisted screening, where basically ranked by relevance. What we've not mentioned, and it was mentioned in passing by Sabina, is in Campbell, South Asia, where the work being done, we use EquiReviewer for doing the maps. So EquiReviewer is systematic review software, which you can use for screening and coding. As we mentioned, also it can do machine learning assisted searching, as well as machine learning assisted screening. The reason why we use EquiReviewer is not only it's built for searching, screening, and coding, is that we, some years ago now, Campbell commissioned Epicenter to produce the EpiMapper software. So EpiMapper is a separate app that generates the maps. You've seen all the maps you've seen are generated using EpiMapper. So you do the coding of the studies in EquiReviewer, save the file, and import it to EpiMapper, and that generates the map. It's a very easy, quick process. And so that's the software we use. As some of you may know, 3IE, International Initiative for Impact Evaluation, also produces evidence maps and has been doing so since before Campbell did. And so 3IE has a separate software for generating maps, where you can code for data in Excel, then input the data into the mapping software. I think they've made the process a bit smoother recently. It used to be quite cumbersome, I would say. But it does have the advantage of being able to code in Excel if you're more comfortable coding in Excel, which people with a lot of experience in doing maps reviews often are. But I would recommend for doing coding for a map or a review with more than 20 or 30 studies, you want to code in a software like Apple Review, not in Excel, despite having some advantages. So that's the questions we had. Is there one more come up? We're going to hand over to Ashrita. That's Ashrita's answer. So I'm going to ask Ashrita and then Sabina if you have any other comments or questions or closing words. If anyone has any questions, you can still stick something in the chat box and we'll try and answer it. Ashrita, anything you want to add?
No, I think it's all clear. I've clearly answered all the things. Just one thing I just want to highlight on the stakeholder consultation thing is, some of the limitations with the wider stakeholder, consultation that we had. I think one of the thing is trying to introduce the intervention categories or, that have a lot of subcategories. And the second thing is obviously because they already have an image in mind in terms of how the intervention and the outcome evidence is based around it. So I think one of the key limitations that we have to be careful about, because they would want to direct the entire, intervention or the things into what they have already in mind. Sorry.
That's a very good point. So I think it's key to emphasize a stakeholder consultation, not being directed by the stakeholders, because people who work on particular programs will want to see that program, and they should be able to identify the category where it is easily, so that the labels need to be clear and transparent. But there's a pressure usually from stakeholders both to expand scope, but also to proliferate the labels, so that it gets too detailed. So we've had maps where the stakeholders come up with a list of like 100 labels, 100 subcategories. Doesn't work well. Ideally, you're going to have 4 to 6 categories and 4 to 6 subcategories for outcomes and interventions. So you have between 20 and 25,000 columns. That's manageable. If you have more than that, the users can't navigate it. It's just too cumbersome to navigate. It's nice if it fits on a single screen, but then you need 10 or 12,000 columns. That's often too few. But if you've got 20, 25, you can sort of keep it in your mind and navigate. Once you've got 100, you just can't find your way. So there is a pressure to proliferate from stakeholders. It should be resisted. Sabina, anything you'd like to add?
Yeah, I think pretty much everything has been said by both you and Ashrita. So I just wanted to highlight stakeholder engagement. Like, for example, this was done at every stage possible, right from the conceptualization till like we are yet to disseminate the findings to the funders and the stakeholders. But even at the stage of coding, we involved the team members from IAVI. We together piloted the coding form and we did code studies. And it's good for both the parties because they also get to learn how we code and they are clearer what kind of what gets coded where. So it was not necessarily only at the level of conceptualization, but pretty much at the every stage, starting from the conceptualization, coding, and various other stages. Thanks.
Thanks, Peter. So there is a Campbell guidance on evidence and gap maps. If you just Google Campbell evidence and gap map guidance, it will come up. It's published in the Conceptual Reviews Journal. And this does emphasize what Sabina was just saying, the importance of stakeholder consultation, including stakeholders in the piloting stage and piloting a lot. So I should just posted the link. So remaining a minute to the webinar, you can click on the link, you'll get taken to the guidance. So that is another webinar now starting by our colleagues in the Collaboration with Environmental Evidence, CEE, of qualitative evidence synthesis. So we're all rushing over there. And so check if you Google it, Collaboration with Environmental Evidence, qualitative synthesis, by Ruth Garside, who is the co-chair of Campbell Methods Group, but also involved with Collaboration with Environmental Evidence. She gave a webinar on this for Campbell last year. I don't know if it's going to be the same webinar or one of the things we've developed since then, because the Campbell Working Group on Qualitative Methods has been working since then, so there may be additional stuff that she's going to be presenting now. So thank you all for joining today's webinar. To repeat that, the Campbell webinar series is sponsored by the American Institute of Research, AER, so we're grateful to them for their support. But the own organisation provides cross support to Campbell, so we're very grateful to them for that support. And they provide support both to Campbell Central and planning to do support to Campbell South Asia as well. So that's very much appreciated. Do look at our program on the website for future webinars that are coming up, both from Campbell Collaboration Centre, where I'm from, but also Campbell South Asia, where Ashrita and Sabina are from. They have their own website, their own series and talks and so on. And to look for ways in which you can engage with Campbell. Who are interested in being a peer reviewer for us, interested in doing a review, don't hesitate to get in touch. We're happy to provide support to you. If you're interested in commissioning a map or review, please do get in touch. We want to know more about the different products we have, because quite a lot we talk about is ongoing, so you won't find it on the website, because it's still ongoing, but we have preliminary versions of these maps, so feel free to get in touch if you would like to see those. So thank you again to everyone, and enjoy the rest of your day, afternoon, evening. As I say, do rush over to the CE webinar, maybe I'll see you there, otherwise we'll see you in the next Campbell webinar. Thank you, everybody. Thank you, Sabina. Thank you, Ashrita.
Thank you. Thank you, everyone. Bye.